Most adults who wake 2, 3, or 4 times every night to use the bathroom eventually arrive at the same conclusion. The problem is their bladder, or in men their prostate, and the solution is to stop drinking fluids after a certain hour and to accept that this is simply what the body does after a certain age. And so they restrict their evening water, they eat an early dinner, they plan their evening around the awareness that the night will be interrupted, and they carry the tiredness of fragmented sleep through their days as though it were an invoice that arrived with turning 65 and must simply be paid. What I want to tell you today is that in a significant proportion of adults experiencing this pattern, the bladder is not the primary problem. The bladder is simply the location where the problem becomes visible. The primary problem is somewhere else entirely, somewhere in the circulation, in the cardiovascular system, in the fluid-regulating hormones, or in the metabolic environment that collectively determines not how much the bladder holds, but how much urine the kidneys are producing during the night, and why. And when the source is correctly identified, the solution is very different from an earlier last drink of water, and the improvement in sleep quality and in the underlying health condition driving the symptom can be substantial. Before anything else, what I share in this video is educational information only. It is not medical advice. If you are experiencing significant nighttime urination, particularly if it has worsened recently, if it is accompanied by leg swelling, breathlessness, or a racing heart, or if you have any history of cardiovascular or kidney disease, please speak with your healthcare provider promptly. What I want to give you today is the framework to understand what your body is doing during the night and the specific questions to bring to your next appointment. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. Nocturia, the medical term for waking to urinate at night, is one of the most consistently undertreated conditions I encounter in this age group, not because there is nothing to be done, but because the conversation stops too early, at the bladder, before reaching the systems that are actually driving the problem. This video is about what lies beyond that early stopping point. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body is communicating after 60, and this video may fundamentally change how you understand a symptom you have been managing rather than treating. Let me begin with the normal fluid physiology of sleep, because understanding what a healthy system does overnight makes the abnormal patterns immediately recognizable. During the waking hours, the kidneys filter approximately 1 liter of blood per minute, and produce urine continuously at a rate that varies with fluid intake, activity, and temperature. In a healthy adult who drinks adequately during the day, urine production runs at roughly 50 to 100 milliliters per hour through the waking period. At night, this changes. The pituitary gland increases its production of a hormone called antidiuretic hormone, also known as vasopressin or ADH. Vasopressin signals the collecting ducts of the kidney to reabsorb more water from the urine being produced, concentrating it and reducing its volume significantly. In a healthy adult with normal vasopressin function, overnight urine production falls to approximately 30 to 50% of the daytime rate. The bladder fills slowly enough that a full night of sleep is achievable before it reaches the volume that triggers the need to void. This is the physiological design of the system. Daytime for active urine production, nighttime for concentrated, low-volume output that protects sleep. When this balance is disrupted, and specifically when the overnight urine volume exceeds 33% of the total daily urine output, a condition called nocturnal polyuria, the bladder fills faster than the sleep architecture can accommodate. The person wakes not because their bladder is abnormally small or abnormally sensitive, but because the kidneys are producing urine at a rate closer to the daytime rate than the intended nighttime rate, and the bladder is simply doing its job of signaling when it reaches capacity. This distinction matters enormously. An adult whose primary problem is nocturnal polyuria does not have a bladder problem. They have a fluid redistribution problem, a hormonal problem, a cardiovascular problem, or a metabolic problem that is driving the kidneys to produce urine at the wrong time of day. Treating the bladder, or restricting evening fluids, addresses the container while the faucet runs unchecked. The single most important and most consistently overlooked cause of nocturnal polyuria in adults over 60 is the one I want to spend the most time on, because it operates silently during the day, becomes visible only when the person lies down at night, and is directly connected to cardiovascular health in a way that makes it both more urgent and more treatable than a simple bladder or prostate issue. Fluid redistribution from the lower limbs. Your size. Here is the mechanism. Throughout the waking hours, gravity draws fluid from the circulatory system into the tissue of the legs and ankles. In a healthy adult with strong venous valves, an active calf muscle pump from regular movement, and adequate cardiac output to maintain central venous pressure, this process is largely offset by the continuous return of fluid from the peripheral tissue back into the central circulation. Some ankle swelling by the end of the day is common even in healthy adults, but it is modest. In adults with any degree of venous insufficiency, in adults with early cardiac dysfunction where the right heart is not generating adequate pressure to draw venous blood from the periphery, in adults who are largely sedentary, and in adults taking certain medications that cause peripheral vasodilation as a side effect, fluid accumulation in the lower limbs during the day can be substantial. The ankles and lower legs visibly swell by the afternoon. The person may notice their shoes feel tight, that there is a puffy quality to the skin above the ankles that improves overnight. When that person lies down for sleep, the gravitational gradient that was trapping fluid in the lower limbs is removed. The accumulated fluid redistributes, moving back from the legs into the central circulatory volume. The heart now receives a higher volume of venous return than it was managing while the person was upright. The increased right atrial filling stretches the atrial wall, which triggers the release of a hormone called atrial natriuretic peptide, ANP. ANP signals the kidneys to increase sodium and water excretion to reduce the blood volume that the heart is now perceiving as excessive. The kidneys comply. They produce urine, and because this redistribution process peaks in the first 2 to 4 hours after lying down, the urine production is concentrated in the early night. The person wakes to urinate an hour or two after going to bed, then again an hour or two after that, producing volumes that are often larger than expected, given how little they drank in the evening, because the fluid being excreted is not from recent drinking. Indice, it is from the legs. A study published in the Journal of Clinical Sleep Medicine found that the volume of lower limb fluid accumulated during the day was directly correlated with the frequency of nighttime urination and with the total nocturnal urine volume, independently of age, prostate size, and evening fluid intake. The legs, not the bladder, were the primary driver of the nighttime pattern in the adults with the most significant fluid accumulation. Type in the comments right now whether your ankles or lower legs are noticeably more swollen at the end of the day than they are in the morning, because the answer to that question is the most important piece of information for understanding whether fluid redistribution is a significant contributor to your nighttime pattern. The cardiovascular connection to this fluid redistribution mechanism is what gives nocturia its significance beyond the sleep disruption it causes, because the degree of lower limb fluid accumulation reflects the state of the cardiovascular and venous systems in ways that matter for long-term health. Significant daytime lower limb edema, the swelling that underlies the fluid redistribution driving nocturnal polyuria, has a differential diagnosis that includes several conditions requiring specific medical management. These conditions include right-sided heart failure, in which the failing right ventricle generates insufficient pressure to draw venous blood from the periphery, allowing it to pool in the lower limbs. Chronic venous insufficiency, in which incompetent venous valves fail to prevent backflow, allowing blood to pool below the knee. And hypoalbuminemia, low blood protein from kidney or liver disease, which reduces the osmotic pressure-keeping fluid within the blood vessels and allows it to leak into surrounding tissue. In adults with right-sided heart failure, the nocturia from fluid redistribution is often one of the first and most noticeable symptoms, appearing before overt breathlessness at rest, and sometimes before the swelling becomes dramatic enough to be identified as pathological. The person simply notices they are waking more often to urinate, that the volumes are larger than expected, and that the pattern is worse on days when they have been sitting more and better on days when they have been more active. This specific pattern, nocturia that is worse after sedentary days and better after active ones, is a clinical clue worth reporting to a physician precisely because it reflects a cardiovascular driver rather than a urological one. A study published in the European Journal of Heart Failure found that nocturia frequency was a significant predictor of early-stage heart failure in adults over 60, and that in a cohort of adults presenting with fatigue and nonspecific symptoms, nocturia frequency was among the most sensitive markers for detecting elevated right-sided filling pressures before a formal echocardiographic diagnosis of heart failure had been made. I am not suggesting that everyone who wakes to urinate at night has heart failure. The majority of adults with nocturia do not. But the specific pattern, progressive worsening of nocturia over weeks combined with daytime leg swelling, with exertional breathlessness, or with the kind of fatigue we discussed in the fatigue video on this channel, is a combination that warrants specific cardiac evaluation rather than management with bladder restriction alone. And share this video right now with one person in your life over 60 whose nocturia has been worsening and who also has swollen ankles or increasing breathlessness with activity. Those two findings together carry a different clinical weight than nocturia alone. And if you are not yet subscribed to this channel, tap that button now and ring the bell. I want to tell you about a patient I will call Margaret, 66 years old, retired nurse from Charlotte, North Carolina. She had been waking 3 to 4 times every night to urinate for approximately 8 months, a pattern that had gradually worsened from 1 to 2 times over the preceding 2 years. She had been told by her previous doctor that the pattern was consistent with her age and with mild bladder overactivity. She had tried bladder training exercises with no meaningful improvement. When Margaret came to me, the first thing I asked about was her legs. She mentioned, almost as an afterthought, that her ankles had been consistently swollen by late afternoon for as long as she could remember, and that she had assumed this was venous insufficiency that was simply a feature of her legs. Her shoes were looser in the morning and tight by 5 in the afternoon. On physical examination, she had pitting edema of both lower legs to mid-calf level. Her jugular venous pressure, the visible distension of the neck veins that reflects right-sided cardiac filling pressure, was elevated. Her heart sounds included a quiet, additional sound that is associated with increased right ventricular filling. An echocardiogram identified early right ventricular dysfunction with diastolic impairment and elevated estimated right atrial pressure. Not overt heart failure, but measurable cardiovascular compromise that had been redistributing fluid from her legs to her kidneys every night for at least 8 months. Her nocturia was not a bladder problem. It was her heart telling her, in the language of interrupted sleep, that it was under strain. She was referred to a cardiologist. Her management was adjusted. Her right-sided filling pressures were addressed through a specifically calibrated, diuretic regimen with morning dosing, which reduced the daytime fluid accumulation that was driving the nighttime redistribution. At 3 months, she was waking once per night on most nights. At 6 months, she had several consecutive weeks of sleeping through entirely. She told me, "I was treated for bladder overactivity for 8 months. I told her, your bladder was never the problem. Your bladder was simply the most visible expression of a problem that lived somewhere else entirely." The second major driver of nocturnal polyuria, beyond fluid redistribution, is the disruption of the normal nocturnal vasopressin rise that I described in the physiology section. In healthy adults, vasopressin follows a clear circadian rhythm, rising at night to concentrate the urine and protect sleep. In adults over 60, this rhythm becomes less pronounced for several reasons. The pineal gland, which produces melatonin and which interacts with the vasopressin circadian rhythm through shared hypothalamic circuits, calcifies progressively with age, reducing the amplitude of circadian hormonal cycles. The hypothalamic sensitivity to the normal cues that trigger the nocturnal vasopressin rise decreases, and certain medications, including some antidepressants, diuretics, and anticonvulsants, directly interfere with vasopressin signaling. When the nocturnal vasopressin rise is blunted, the kidneys do not receive the signal to concentrate and reduce urine output. They continue producing urine at a rate closer to the daytime rate throughout the night. The bladder fills at close to the daytime rate, and the person wakes not because they have a bladder problem or a fluid redistribution problem, but because the hormonal instruction to the kidneys to slow down overnight has not been delivered clearly. This mechanism is more common in adults taking multiple medications, in adults with diabetes insipidus of any degree, and in adults with significant sleep disruption from any cause, because the normal vasopressin pulse is partly dependent on the occurrence of deep slow-wave sleep, during which the hypothalamic pulsatile release of vasopressin is strongest. The investigation that directly evaluates this mechanism is a urine osmolality measurement across the day and overnight. An overnight urine that is adequately concentrated, with an osmolality above 700 to 800 milliosmoles per kilogram, indicates that vasopressin is functioning appropriately. An overnight urine that is dilute, despite no excessive evening fluid intake, indicates that the vasopressin concentrating mechanism is impaired. This is not a test that most adults with nocturia have ever been offered. It is available at any laboratory, and its result, combined with the timing and volume pattern of the nocturia, directs the management toward either vasopressin replacement, if the deficiency is significant, towards sleep quality improvement, if sleep disruption is blunting the vasopressin pulse, or toward a medication review, if a drug interaction is the cause. There is one specific pharmacological cause of vasopressin disruption worth naming, because it is common in this age group. Selective serotonin reuptake inhibitors and certain serotonin norepinephrine reuptake inhibitors, prescribed for depression and for the anxiety that is prevalent in adults over 60. These medications can produce a condition called syndrome of inappropriate antidiuretic hormone secretion, or SIADH, in which vasopressin signaling is chronically overactivated rather than underactivated, producing dilutional hyponatremia, low blood sodium. But more commonly in older adults, the same class of medication produces a subtle but measurable disruption to the normal nocturnal vasopressin rhythm through its effects on hypothalamic serotonin circuits, leading to a less pronounced overnight vasopressin peak and correspondingly higher overnight urine production. If you take an antidepressant and have significant nocturia, a specific conversation with your prescribing physician about whether the timing of the medication and its potential effect on nocturnal vasopressin rhythm is worth having. The third mechanism I want to address is one we have discussed in detail in other videos on this channel, but that deserves specific emphasis in the nocturia context: sleep apnea and the atrial natriuretic peptide pathway. We established in the nocturia video earlier in this channel that obstructive sleep apnea produces nocturia through the ANP mechanism. Apnea events cause right atrial stretch, which triggers ANP release, which signals the kidneys to produce more urine. This mechanism is distinct from the fluid redistribution mechanism, but produces a similar outcome and often coexists with it. The distinguishing feature of sleep apnea-driven nocturia is its pattern. It tends to be distributed more evenly through the night, rather than concentrated in the early hours, because the apnea events that drive the ANP release occur throughout the sleep period, rather than only during the redistribution-heavy first few hours. The person waking primarily in the first 2 hours of the night is more likely driven by fluid redistribution. The person waking at similar frequency throughout the night is more likely driven by apnea-related ANP signaling, by vasopressin disruption, or by a combination of mechanisms. If snoring, unrefreshing sleep, morning headaches, or daytime sleepiness accompany the nighttime urination pattern, sleep apnea evaluation is the most important next step. Treatment of sleep apnea with CPAP reliably reduces nocturia frequency in adults with both conditions, as we discussed previously, by removing the apnea events that were driving the ANP signaling without any change to fluid intake, diuretic use, or bladder management. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell, because every week I come here with the specific mechanistic connections that make symptoms understandable rather than mysterious. The fourth mechanism is the one connected most directly to the broader metabolic picture we have discussed across many videos on this channel: elevated blood glucose and the osmotic diuresis it produces. When blood glucose exceeds the kidney's reabsorption threshold of approximately 180 milligrams per deciliter, glucose spills into the urine. Glucose in the urine is osmotically active, meaning it draws water with it as it is excreted, producing a urine volume larger than fluid intake alone would generate. In adults with diabetes or prediabetes whose overnight glucose rises above this threshold, the excess glucose-driven urine production adds to whatever other mechanism is driving nocturnal polyuria and compounds the overall volume. The specific feature that points toward a glucose component is the volume of the nighttime voids. A person producing unusually large volumes of urine overnight, volumes that seem disproportionate to fluid intake, even after accounting for the daytime redistribution of lower limb fluid, may be experiencing glucose-driven osmotic diuresis on top of the other mechanisms. The test is straightforward. An HbA1c and a fasting blood glucose combined with an assessment of overnight glucose level using a simple fingerstick measurement on waking will confirm whether glucose is a contributing driver. There is also a more subtle glucose connection that does not require above-threshold blood glucose levels. The insulin resistance that produces prediabetes also impairs the normal overnight suppression of the renin-angiotensin-aldosterone system, the hormone cascade that manages sodium retention and blood volume. In insulin-resistant adults, this system remains partially active overnight, in a way that promotes a relative sodium and water loss compared to the expected overnight retention, contributing to higher urine volumes than the vasopressin signal alone would produce. Hidden sodium in the diet is the final metabolic contributor I want to address. Adults who eat diets high in processed and restaurant food are frequently consuming far more sodium than they are aware of. High sodium intake drives thirst and high fluid intake, which drives higher urine production across the full 24-hour period, including overnight. And sodium retention in the setting of insulin resistance specifically amplifies the fluid redistribution mechanism I described, because the expanded extracellular volume from sodium retention increases the total pool of fluid available for redistribution when the person lies down. The practical relevance is that addressing the metabolic drivers of nocturia, blood glucose, insulin resistance, and dietary sodium, simultaneously addresses the hormonal and fluid mechanisms through which those metabolic states produce the nighttime pattern. Here is the framework for understanding which mechanism is most likely driving your nocturia, and what the appropriate investigation and management pathway is. The timing and volume of nocturia is the most informative clinical feature for identifying the driver. Nocturia concentrated in the first 2 to 3 hours after lying down, with larger void volumes occurring more often after sedentary days and associated with visible daytime ankle swelling, points toward fluid redistribution from lower limb edema as the primary mechanism. This pathway warrants cardiac evaluation, venous assessment, and a review of medications that cause peripheral vasodilation. Nocturia that is distributed evenly through the night, that is accompanied by unrefreshing sleep, morning headaches, and daytime fatigue, and for which a partner has noticed snoring or breathing pauses, points toward sleep apnea and the ANP mechanism. This pathway warrants a home sleep study. Nocturia with dilute, high-volume overnight voids that are inconsistent with evening fluid intake, particularly in adults with diabetes, prediabetes, or on multiple medications, warrants a urine osmolality measurement, a review of medications affecting vasopressin, and an assessment of overnight glucose levels. Nocturia with any combination of worsening exertional breathlessness, progressive ankle swelling, and new nocturnal cough or the need to sleep propped up on multiple pillows warrants same-day or urgent evaluation for heart failure, because these features together constitute a cardiac emergency signal rather than a chronic nocturia management question. The practical interventions that address the fluid redistribution mechanism specifically, while awaiting or alongside a medical evaluation, are the following. Wearing compression stockings during the day prevents the daytime lower limb fluid accumulation that drives the nocturnal redistribution. Multiple clinical studies have found that daytime compression stocking use reduces nocturnal urine volume in adults with lower limb edema, in some cases reducing the number of nighttime voids by 1 or more per night. The stockings need to be graduated compression, meaning they apply more pressure at the ankle than at the calf, and they need to be worn during the hours of upright activity rather than during sleep. Elevating the legs for 30 to 60 minutes in the late afternoon, before lying down for sleep, allows the pooled fluid to return to the central circulation while the person is still awake and mobile. The kidneys then process the returning fluid volume during the evening waking hours rather than during the first hours of sleep. This shift in the timing of the fluid redistribution, moved earlier by the deliberate elevation, correspondingly shifts the timing of the resulting urine production earlier, reducing the nighttime burden. Ensuring that any diuretic medication is dosed in the morning, or at the latest in the early afternoon, so that its peak fluid excretion effect occurs during waking hours when urination is convenient rather than during the night, is one of the simplest and most effective modifications for diuretic-related nocturia. We discussed this specifically in the previous nocturia video on this channel. A specific conversation with a prescribing physician about whether any currently prescribed medication, including certain calcium channel blockers that cause peripheral vasodilation as a side effect, is contributing to lower limb fluid accumulation, may identify a modifiable pharmacological cause that has not previously been recognized as relevant to the sleep pattern. 4 things to carry away. First, nocturnal polyuria, the production of urine volumes at night that exceed the normal nighttime proportion of daily urine output, is driven by specific mechanisms that are largely independent of the bladder and largely invisible to bladder-focused management. Identifying the mechanism changes the management pathway from restriction to treatment. Second, Fluid redistribution from daytime lower limb edema is the most commonly missed and most clinically significant driver of nocturia in adults over 60. Daytime ankle swelling that redistributes overnight is directly linked to cardiovascular function, and worsening nocturia alongside worsening swelling deserves cardiac evaluation rather than bladder management. Third, the timing and volume pattern of nocturia is diagnostically useful. Early night, large volume voids point toward redistribution. Evenly distributed, moderate volume voids point toward apnea or vasopressin impairment. Large volume, dilute voids point toward glucose or vasopressin mechanisms. This specific description, brought to a physician, transforms a nonspecific complaint into a targeted diagnostic pathway. Fourth, the cardiovascular conditions that drive nocturia through fluid redistribution and ANP signaling, right ventricular dysfunction, venous insufficiency, and in some cases early heart failure, are conditions where early identification produces meaningfully better outcomes than late identification. A worsening nocturia pattern is not only a sleep problem. In the right context, it is the earliest visible signal of cardiovascular compromise that deserves specific investigation. You are not simply waking at night because your bladder has aged. You are waking because the kidneys are producing urine at the wrong time of day, and the reason for that timing is written in the fluid balance, the cardiovascular function, the hormonal signaling, and the metabolic state of the body that contains both of them. Finding the reason changes the outcome in a way that managing the symptom never will. Share this video with one person in your life over 60 who has been told their nocturia is a bladder issue and whose ankles are swollen by the end of every day. And subscribe to this channel because every week I come here with one purpose: to give you the specific understanding that turns a symptom into a conversation and a conversation into a solution. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.